All right. Hi, everyone. Welcome back to your second clinical skills lecture for this semester. We're going to be looking at the hematological system this time around. And I know that your booklet says it's history, examination, and investigations, but really the focus is more on the history and examination. When you start doing your hematological kind of lectures, you'll focus more on how to interpret blood films and other components of the hematological system. So for today, we'll focus on the first two aspects. But if you do have any questions or concerns, feel free to send those questions our way, either through direct messages or even just popping a question in the comments. We're happy with either. Okay, without any further ado, let's get started. So just starting off strong with sort of your systems reviews and the type of things you'll be asking in your history. The hematological system is not one of those like black and white systems where, for example, in cardio, you're always going to be asking about shortness of breath. You're always going to be asking about chest pain. You're always going to be asking about calf pain. It's not really along those lines. And so sometimes it can feel like some of these questions are a little bit vague. But what I've tried to do is to give you a better way to remember them. I've broken it up into the different types of cells that you're targeting. So, for example, if you're thinking about a red blood cell problem, you're thinking about too little or too much. Same thing with white blood cells, same thing with platelets, and of course, your malignancies. So, with all of these, I've tried to group them into the main questions you want to ask, and that can be big red flags. So, for example, with red blood cells, the main kind of idea you're trying to rule out or rule in is the idea of an anemia. So fatigue, shortness of breath, palpitations, and pallor are all sort of non-specific but still useful signs to be able to distinguish if someone needs further investigations for an anemic cause. Now, if you're thinking along the lines of anemia, it becomes important to also ask about their diet, which you kind of do in the social history anyways. But things like if they're on a completely vegan diet, if they're on a tea and toast diet, or things where you can expect some sort of micronutrient deficiency. And the main ones we ask about are going to be iron related or B12 related. You've also got if they have any history of bleeding, right? So in this case, you might want to be like, if this is a female patient that we have, you might want to ask about their periods and asking if they're heavier than before or lighter than before. You can ask in any patient if they've had recent surgeries, because of course, if you have, for example, a lower GI bleed or you have signs of anemia in a elderly patient, you're suspecting some sort of bleed within the gastrointestinal tract. So you want to be really careful to rule in or rule out these sort of complications. With white blood cells, the main one you're considering is going to be low white blood cells, so leukopenia. And it's really simple because you're just asking if they've had any recurrent infections, or they've had any fevers or infections really that have taken a really long time for them to get over. So, if they've had the common cold and you would expect them to get better within about a week's time, but they've actually had this for a couple of weeks, then you're thinking, okay, this is not normal, right? This is not how long it should take for them to resolve. Then you've got platelet disorders. In this one, I think it's actually important to consider whether they have too much or too many. If they have, too little or too many. So if it's too little, we call it thrombocytopenia. And this is quite simple. If you don't have enough platelets, you're not going to be able to coagulate or form your clots. So you're going to have very easy bruising or bleeding, or you might have some signs of atypical bruising or bleeding. So this can be like gum bleeding, which is not really common, right? You won't just spontaneously bleed from the gums, but if that's a spontaneous thing that's happening, it might raise your suspicion for just like minor traumas causing bleeds. Another one would be nosebleeds, right? Some people have I guess it's more common for them to bleed from their nose. For others, it's like, for example, I've never had a nosebleed in my life, but I know some friends who have recurrent nose bleeding, and it could be potentially due to a loss of these platelets. Another one would be too many platelets, or thrombocytosis. So in this case, now you're clotting too much, right? And this can be usually like hereditary forms of these sorts of conditions. So ask them about risk factors that would lead you towards thinking about a DVT, so a deep vein thrombosis, or a pulmonary embolism. So, shortness of breath, have they had any leg pain, that kind of thing. Cough as well, or blood in the cough. Obviously, with all systems, you're going to screen for your malignancies, but it's even more important with your blood cancers. So the main ones you want to be asking about are loss of weight, fatigue, fever, and night sweats. So the four sort of constitutional things you ask for all histories. With the systems review for hematological, it also is very important to ask about bone pain, because that can be a pretty typical sign of someone who has some sort of bone marrow malignancy. So obviously the classic things you're screening for are going to be all the types of cancers here. So leukemia, lymphoma, myeloma, and so on. You learn about each of these, I guess, the more specific signs you might look for some of these ones. But when you're really just doing kind of like a catch-all in your systems review, you just want to make sure that you have an idea that this is a malignancy or it's not a malignancy. Okay, now, the actual kind of main points that come out of the hematological system is actually within the examination. So now you've had a bit of an idea in your mind of what's going on. You want to then focus your examination to look for signs that support your hypothesis. So just on general inspection, some things you might consider are, obviously the appearance of the patient. So looking at their posture, body habitus, how comfortable they are, whether they have anything around them that would be suggestive of some sort of problems with this system. I can't really think of anything off the top of my head that would be for hematological, but I guess you could look for cannulas, you can look if bloods have been taken or, sort of those sorts of things, but nothing really specific. You can also look for obvious signs of any skin discolorations. So the three main ones would be pallor, which would indicate some form of anemia, jaundice, which can be some form of hemolytic anemia, and then plethora, which is a classic sign of polycythemia rubra, or just polycythemia, which is an excess of red blood cells. Skin changes wise, you might see some very obvious bruising, so petechiae, so just really small spots of redness, and then ecchymosis, as well as scratch marks, which are seen in itching or pruritus. So that bruising is pretty classic of some sort of bleeding diathesis or an ease of bleeding, like an abnormal ease to bleed, whereas a pruritus can be, again, a sign of polycythemia rubra. So classically, patients with polycythemia, they tend to have more itching after they've had a hot shower. So I guess you can ask that in a history, but yeah, you don't have to always include like, do you itch after you shower? Because it's a very specific thing to ask. And unless you have a suspicion, it doesn't really make sense to put that out there. So you might just examine it and see if they don't have any scratch marks. It's unlikely for them to have a pruritus. Okay, now going to the upper limb, some of the, I guess, more buzzwordy things you should be looking for would be classically koilonychia. So you do this to an extent in a GIT exam as well, but here it's more specific because you're screening for an iron deficiency anemia. So you're looking for those classic spoon-shaped brittle fingernails. Digital infarctions are also a specific sign for an embolus that has managed to find its way into a small blood vessel. Not very common because you would need a very, very small embolus and it would have to reach all the way down into the distal circulation. So a lot of these signs you'll find, they're buzzwordy, but they're also very, very rare. And of course, with the digital infarct, you're thinking about a thrombotic disorder. Palm inspections, this is a pretty good one for anemia, so pale palmar creases. And then also some rheumatoid manifestations. So in a myeloproliferative neoplasm, you can have an association with gouty arthritis because you have a pretty massive turnover of cells. And some of those excess ions and things that are released from those dead cells can lead to an accumulation of uric acid crystals and therefore lead to gouty arthritis. Again, not very common, but if you can see it, may as well note it down, right? So that's upper limb. When we get to face and neck, we're kind of looking for similar things that we just had a look at. So of course, you're looking for pallor, jaundice, and plethora. Plethora is more so just like the face in general, whereas pallor and jaundice, they usually start, I guess, in the eyes. So you're gonna see the eye signs more, or I guess earlier, then you're gonna see the entire face change into that color. So the thing that is kind of common to all your exams is you're gonna ask the patient to pull their eyelids down and look up straight ahead. And then you can ask them to pull their upper eyelids up and then look straight down. So you're looking for these two things on those kind of that inspection. Subconjunctival hemorrhage is also an easy one to look for in bleeding diathesis because those arteries are very, very small and very delicate. So you might see someone who has little red splotches all over their eyes, which indicate that they've been bleeding. In the mouth, you're looking for signs of infection. So on the tongue, you can look for thrush as well as any ulcers. And this is classically in leukemia, patients can be predisposed to opportunistic infections, like with candida. The gums, this is a pretty buzzwordy one. So if you have a gingivitis or you have a gingival hyperplasia, then you're thinking along the lines of an AML, right? And the reason why is not very well researched, so why one leads to the other. But if you do see a gingival hyperplasia, you're thinking acute myeloid leukemia. Of course, also that bleeding diathesis. So remember we talked about abnormal places for people to bleed from spontaneously. That could indicate a lack of those platelets. And then, of course, signs of vitamin deficiency. So angular stomatitis along sort of here, when you see, I guess you can see cuts on the sides here. And then glossitis, which is a shiny looking tongue that has lost its papillae. So classically in vitamin B12 deficiency. Okay, a very, very important part that a lot of students forget is the examination of the lymph nodes when it comes to hematological. Because, of course, you can get lymphomas, so like these lymph nodes can become enlarged, but there can also be signs of metastasis, right? So you want to be really careful that you're examining all the lymph nodes that are relevant to this particular patient. At a second year level, you just want to do all of them, right? So you're going to start with the arms, or you can start with anyone, but I like to start with the arms. You're looking at the epitrochlear, which is along the medial arm, and it's at the front of the elbow. So I would encourage you to look at a picture of what this looks like, because you will be asked to assess the epitrochlear ones. And then you know the axillary from all the way back to upper limb anatomy. So you know that there's approximately 5 groups within the armpit region that you need to feel for: anterior, central, posterior, lateral, and apical. The abdominal ones, they're the para-aortic nodes. So kind of in the same way that you palpate for the aorta, you're going to just feel on either side of the aorta for any enlarged nodes. Very difficult to feel these ones unless they are extremely enlarged. So don't expect to find much. And then in the leg, you've got the inguinal as well as the popliteal groups, right? I forgot to mention as well with the neck, you've got the cervical and supraclavicular. It's a good to get into the habit of just knowing exactly what all the cervical lymph nodes are. I didn't really learn these at a second year level, but now that we're doing it often in the clinic, I think it's just important to know exactly which areas correspond to which cervical nodes. So you've got the submental, submandibular, you work your way back, parotids, you got the preauricular, postauricular, and so on down into the cervical group as well. So you want to be really, really careful that you know these ones. And then, of course, the supraclavicular ones. How to interpret them? Well, you're going to comment on a lot of things. So you're going to say, first of all, where is it? What is the most likely group of nodes that are affected? And if you have a knowledge as well of which areas they drain, that can be super helpful, but it's not that relevant to know at this stage. You can also assess the size, and if you can give a number, that's good as well, because it gives whoever you're reporting to an idea of how serious this is. Think about the shape. So shape, what I mean by that is it kind of a smooth, circular, and well circumscribed lymph node, or does it feel kind of irregular, or in other words, like spiky? Because if it's irregular, that is a sign that gives you a point towards this being a malignancy. You also have consistency. So is it smooth? Is it rubbery? Is it hard? Tenderness. So is it painful to touch, or is it even painful at rest? As well as mobility. So is it fixed to the underlying muscles or the underlying soft tissue, or can you actually move it around between your fingers? So again, to interpret this, you're essentially looking for things that are consistent with an infection or consistent with a malignancy. So with infectious lymph nodes, so ones that have been inflamed, you're thinking that this is going to be a painful lymph node. It's going to be potentially still soft, maybe a little bit hard, but usually soft. Obviously quite large, but it's not going to be fixed to the underlying tissue. Okay, so that's what you're thinking along the lines for infection. When you're thinking about a malignancy, this is going to be an irregular lymph node. It's going to be fixed to the tissue because you're realizing that this is now infiltrated into the surrounding space, and it's also going to be non-tender. So, kind of contrary to what we think, because it's not painful, it doesn't mean that it's not serious, because usually the infectious ones are the ones that are painful. The malignant ones are not painful. You've also got the firm and rubbery kind of like appearance or palpation, and that's classically associated with a lymphoma. So if you see firm and rubbery, or even if you feel something that's firm and rubbery, be sure to rule out a lymphoma via your investigations. Back and lower limb. This one's very, very straightforward, and you can get this done within about 10, 15 seconds. So bony tenderness, like we mentioned with our history taking, you're trying to rule out bone marrow diseases and bone cancers. So at the spine, you tap it with the medial fist. So you're kind of going like this with your hand, and you're kind of just like tapping against the spine from the back. At the clavicle or the sternum, you're just using the heel of your hand. So you just kind of like pat them essentially. You don't want to like hit them hard to elicit tenderness. You're just patting them and feeling or asking them, or even looking at their face to see if they have any sort of response. Because obviously in a normal patient, you're not going to really have any pain if someone hits you against the bones, because the bones are very strong. In the lower limb, same things as you did in the upper limb. bruising, petechiae, pigmentation. So we looked at the pallor, we looked at the fact that there is any plethora, jaundice, that kind of thing, but it's a little bit less common to see them in the lower limb first. Scratching for the pruritus, we see in polycythemia. Any edema or neurological changes that can be associated with other complications, which we're not going to go into a lot of detail here, but I think it's just a good habit to get into when we look at lower limb manifestations. We want to still be considering other differentials as well. So, for example, heart failure and that kind of thing, you want to be considering in this case. And the last thing is the abdominal examination. So inspection-wise, same things as you did in your regular abdominal examination. So any distension that could indicate ascites, masses, swellings, scars, and any asymmetry that you can view when the patient is supine. Palpation-wise, do the same thing. So light and deep press of the quadrants. The main organs that you're feeling for here, or even when you're percussing, is going to be the liver and the spleen. Because in a hematological scenario, the spleen is the one, remember, that is the manufacturing place for a lot of these blood cells. And also when you have some sort of platelet abnormality, the platelets tend to, I forget the word, they kind of like accumulate within the spleen. So they get concentrated there, and then you get a splenomegaly. So a splenomegaly, just know the features of what you should expect when the spleen is enlarged. Remember that as opposed to the liver, which kind of enlarges straight downwards on the right-hand side of the abdomen, the spleen starts on the left-hand side because that's where it's located, just underneath the ribs. But when it enlarges, it goes inferomedially. In other words, it travels diagonally down to the right lower quadrant. So that's where you'll feel the superior border. And also the spleen has a notch on its medial aspect, which is not normally palpable because it's covered by the ribs. But once it gets enlarged, you might be able to feel a palpable notch. And so, buzzword, right? So if you hear the word palpable notch, that's going to be the spleen and pretty much nothing else. Okay. So these are the main things you're going to be looking for in a hematological exam. I know you can sort of tell that it's not a very long exam. And the reason why is because there's probably a lot more to the hematological exam once you develop an itinerary of all the different hematological conditions that you can come across, which will happen in your hematological lectures. But they're so very specific that only if you were really, really certain that a patient had this particular condition, would you be looking for those extra little niche ideas. But in the case of just a broad hematological examination, when you don't really have much of an idea of what's going on, these are the main things that you would be considering to rule in or rule out major conditions. So I guess the main conditions you should be focusing on here would be your anemias and your blood cancers, as well as potentially any low platelet disorders, right? Those are the three main things you're really looking for in examination. So I think that's it for today. If there's any questions at all, please let me know. I'm happy to answer them either in our live sessions or through messages. And if you have, and I guess the main tip that I would give to you for your physical examinations is make sure you keep practicing them, because oftentimes you might not have that many opportunities to practice a huge number of these in the clinical lab scenario, especially with COVID happening. So I would recommend either practicing on family or friends, or practicing on like a dummy or something like that, which is what I did. I just did it with like a soft toy. It can get you into the rhythm of just looking for these things rather than having to stop and think. Because once you get to sort of your third year, fourth year level, it's more so about the interpretation of what you find than actually just following the steps. Okay, cool. Best of luck, and I'll see you next week for another set of lectures. Bye-bye.